Laurie, hi. Thanks for joining us.
Hi, Peter.
Really excited to have you as we celebrate 30 years of HealthRight and Jonathan Mann's legacy. I honestly, I couldn't think of anybody better to talk to at this moment. Again, considering Jonathan's legacy in health and human rights and the work that HealthRight does around the world with a focus on marginalized communities, I wonder if we could just start off with you reflecting a bit about Jonathan, his legacy, and the ways in which this notion of health and human rights has impacted the practice of public health globally. You've been you've sort of had a front row seat to all of this. So I'd love to just get your reflections at this moment.
Yeah, it was very obvious from the beginning of the HIV catastrophe that people were paying a price for having a sexuality, for having a lifestyle, for having lovers that were not of the opposite gender. And that there were those in power in countries all over the world who saw this as a moment to exploit prior agendas, whether it was lock up all the prostitutes in country A or, more punitive laws against homosexuality in country B, or lock up all the IV drug users in country C. All over the world, we had an epidemic being greeted not as a public health event, not as a viral assault, but as an event of amoral people whose activities and beliefs must be prosecuted. And, Jonathan came from a medical background, but he was heavily influenced by his brother, who was a rabbi, and long hours of conversations about morality and values. And he very much believed that public health functioned best, not based on its technology and its toolkit, but based on its relationship to the communities it was serving. And so, that was Jonathan's mantra. Along came Danielle Tarantola, a very outspoken, seasoned veteran of the smallpox battles who came from Corsica. And Danielle introduced Jonathan to the Helsinki Accords and said, there's a legal framework for this. Human rights are an integral part of public health. It's in the law of international accords. And, Jonathan studied the Helsinki Accords and said, wow, this is my toolkit. And when he moved from Zaire to take over creating the Global Program on AIDS at GPA at WHO in Geneva, he had already decided to build it on this framework of human rights. And that became a real bone of contention between the GPA gang and the rest of WHO. It wasn't common within the World Health Organization in those days to predicate policy on public health and human rights together, side by side. That just wasn't the norm. There were individuals that practiced accordingly, but it wasn't WHO policy. And then when he left WHO and went to Harvard, Jonathan created a team, some of whom had been part of his program at WHO, that started to do basically what he had felt was the role of the World Health Organization, which the agency abdicated. So they were trying to track the epidemic, figure out how it was spreading, figure out what kinds of interventions were working around the world, which ones were failing, and build programs accordingly.
Do you think, and so to what degree do you think the global health community has sort of adopted now, as we've entered into the global HIV response has really completely reshaped the global health landscape in many ways. To what degree do you think health and human rights has been adopted as a framework for viewing this kind of public health work, or not? Is there still a lot of work to be done in that regard?
Well, I think human rights is now very much integrated into all of the public health educational apparatus, so that almost anywhere you go in the world, except the small list of countries you can think of,
Yeah.
you know what I'm talking about, but almost everywhere else you go in the world, human rights is part of the public health agenda, and it's trained from day one in schools of public health. So if you're going to go for a graduate degree, you may be in a very empirical area. Perhaps you love statistics, but you will be exposed to the notion that the statistics are telling a story that's related to the human rights of the individuals you're tracking. If anything, I would say it's almost swung way too far in another direction, because it's easy to gain credibility now in the public health community using a human rights message, right? Framing your arguments in proper messaging about racism, sexism, marginalization of populations, using all the buzzwords that I just used. But you can have bogus science behind you.
Yeah.
So I think the real challenge is going the next step to say both must be rigorous. Both must be based in really empirical evidence. You don't just vaguely assume that everybody agrees with you that racism is bad. And you don't just vaguely assume that smoking is bad. We have to prove smoking is bad. We have to prove there is racism built into a program and attack it accordingly. And I think that's where things have gotten a bit sloppy, and there's need for rigor.
Yeah. Speaking of data and data telling stories, let's shift gears slightly to this moment, this pandemic moment. I'm wondering what this moment, this pandemic moment, and the current movement for racial justice say about the interplay between health and human rights, and and how should, obviously there are many mistakes have been made, particularly in this country in terms of the COVID response, but how should health and human rights inform both our thinking about COVID as well as our response, our actual response to COVID? We've already seen that disproportionately we're seeing, minorities disproportionately affected by COVID. How should we be thinking about this moment through that particular lens?
Well, COVID is clearly plaguing every single population on Earth, and every racial group, every ethnic group. So it is, as a virus, as a biological entity, is non-discriminatory, right? It's after every human host. So the elements of the racial bias in case burden, both infection and severity of disease, are reflections of issues of humans and human behavior, not of the virus. And I think it's really important to make that distinction, because I've heard some sweeping comments that from people who should know better, saying things like, this is a disease of color.
Right.
Well, no, the virus does not recognize race, right? But we have created social constructs in our health system, in our labor system, in our system of access to care, that is rife with racial burden, is rife with gender burden, and is affecting who's getting infected. I mean, to me, the most startling thing that just blows my mind about the American situation is that we know the number one marker for likely severe outcome with COVID infection is a history of hypertension. Nothing comes close. There are other cofactors, but hypertension appears to be, a marker for a larger scale metabolic disruption, and that's got to be the easiest test to perform, a blood pressure test. It can be performed by somebody with zero medical training. All you have to know is slap the cuff on,
Yeah.
listen, get your cues,
Yeah.
write down the numbers, right? And it ought to be, I mean, if our method of handling COVID, we're not a medical method, but we're a genuine public health method, then every single testing station for COVID would automatically conduct blood pressure tests,
Yeah.
and would automatically refer anyone showing high blood pressure or a propensity in that direction for education about nutrition, proper medication, supply the medication free. You're in an epidemic, man.
Yeah.
Let's, the cost is so minimal. Supply the medication free, create follow-up appointments for making sure that the meds are properly calibrated to the individual. And, make sure they really understand what is hypertension.
Yeah.
What does it mean is happening in your body and in your heart?
Right.
And what can you do about it? The fact that we're not taking such a cheap, obvious intervention at this time on a mass scale nationwide, the fact that, I mean, if you wanted to really be bold, every time somebody's in one of these drive into your parking lot at Walmart to get your COVID test things, why not, while they're in that huge queue of cars waiting for 4 hours to get tested for a useless test that, by the way, they won't have results from for a week or two, after which point it's meaningless, right? But you could do something meaningful while they're in that line. For a hypertension test, blood pressure, and while you're at it, offer pinprick blood glucose testing.
Yeah.
And you would identify huge numbers of either never diagnosed or never properly treated diabetes, heart disease, hypertension, and save millions of lives.
Yeah.
Why is this like a wild idea?
I know.
And I know if Jonathan Mann were alive today, I know he would be screaming about that.
Yeah.
And it would be part of his agenda. Yeah. Just as, I mean, a public health individual can say what they want about racial contributors to disease, but there are certain things where you can take action. You don't merely need to bemoan the condition. And this seems such an obvious one.
I know it's a classic narrow medical view of a public health problem and a solution that's sort of born out of that. I agree. It's such a massive missed opportunity. It's really incredible. Let's shift slightly our geography and talk about, I'd love to get your take on what's going on with COVID in sub-Saharan Africa. Really interesting case. You and I spoke early on, and I think, we agree that this could largely end up being a silent epidemic with lots of people just dying at home for a variety of reasons. It doesn't as yet appear to be as severe as some people had anticipated. What are your, I certainly have thoughts on what's going on. I'd love to get your take on what you think is going on with COVID in Africa specifically.
Well, I think, first of all, if there's ever been a case where it's wrong to refer to Africa as a singular event, this is the one, because we have highly diverse populations, highly diverse quality of healthcare, and conditions under which people live, and their possibility of social distancing and so on all over the continent. Very, very different dynamics. The second thing I would say is that just about every single database I know of is saying it's an undercount. That whatever numbers you think you're seeing about COVID in Africa are grossly understating the reality.
For sure.
And some of that is about self-diagnosis. I think, if you're in almost any community in the United States today, regardless of your economic status, how remote your home may be, whatever, you've heard of COVID by now. There's a pandemic. There is, it gives you pneumonia. right? You know some of the basics about it. And so your index of suspicion is high. If you start to have trouble breathing, if you find yourself coughing uncontrollably, you run a high fever for several days, you have profound exhaustion, you think, oh, I wonder if I have this new disease. Maybe I should see somebody. Is there some place I can get a test?
Yeah.
But if you're in Africa today, many parts of the continent, there's no way you've even heard of COVID.
Mm-hmm.
You don't even know there's a new disease in the world.
Right.
If you are fortunate enough that you live in, a very internet connected urban area, say Nairobi or Johannesburg, okay, you know there's this disease, but then do you know where to go if you have it? If you're living in Soweto, your options are very limited. There aren't a lot of health services available where people have full PPE and feel safe and comfortable about processing you as a patient, putting themselves at risk. So I think what we're looking at with Africa right now is a combination of reasons that both as health consumers, people are unaware of the true severity and nature of the disease. Mm-hmm. And as health providers, they're under-resourced and unlikely to be fully protected and feel safe in various parts of the continent in directly interacting with patients. And then one last thing that obviously is happening is the supply chains are disrupted by this epidemic, and that includes access to antiretrovirals, to anti-tuberculosis, anti-malaria drugs. And so in a horrible, twisted way, I think this is further complicating diagnosis. Mm-hmm. I mean, if you have a long-standing battle with tuberculosis, you've been taking your meds regularly, you are in recovery, you no longer have profound respiratory symptoms, mm-hmm. And then all of a sudden you start having them again. Is it because your local clinic ran out of the antibiotic cocktail you were taking, or is it because you have COVID? Yeah. Which is the reason that you're having trouble breathing? And similarly with HIV, if you just suddenly have a symptom of profound fatigue, is it because you're not taking your antiretrovirals at the moment, or is it because you have COVID?
Yeah. And as you say, the other obvious problem is that data collection systems across sub-Saharan Africa are notoriously poor. You have sort of moments on the continent where, in certain places where you have relatively reasonable data collection, but by and large it's very poor. The way that they document mortality is certainly not happening with things locked down, and things are concerningly, things are also just starting to open up after a pretty severe lockdown, which is the other thing that happened. Lots of countries just really just sort of flip the switch and shut things off, and so I think it'll be interesting to see how things play out there. I'm interested too in the interplay between the youth dividend that you would see in Africa, and how that plays off the relatively higher burden of other infections that would seemingly predispose you to more severe disease from COVID. TB epidemics, which you mentioned, HIV, obviously. So as you get more into Southern Africa, certainly you have more HIV, more tuberculosis, co-infection, COVID, TB, co-infection, malaria, and see how that plays out. Just people have made a lot of the youth dividend, but that's also, I would think that would be tempered by the relatively higher prevalence of infectious diseases, and by the way, also chronic, because chronic diseases, as you're well aware, have been going up on the continent as well.
Well, it's interesting. I was reading just last week about a boat of refugees from Northern Africa and mm-hmm. West Africa that had passed through Libya, which is this horrible situation now, where most of the refugees are passing through this very corrupt, failed state. And they were all on a boat together that was stuck at sea for several days. By the time they reached whatever Greek island it was that they ended up landing on, the majority were COVID positive. Mm-hmm. So, here you are, you're locked down on a boat together. You have no choice but to be shoulder to shoulder with the person next to you on each side in your boat. And they were all young men, young adults, usually your healthiest age group.
Yeah.
So I think the youth bulge of Africa, the youth benefit, the youth bulge, whichever way you want to look at it, certainly it benefits long term the future of Africa, because it becomes a vibrant society looking ahead 20, 30 years from now, compared to the aging society of China, the aging parts of India, and certainly the aging of most of the competitive regions of Asia.
Yeah.
But if that carries with it high risk for infectious disease because of youthful behavior issues, then the benefit could turn into quite the opposite.
Yeah, exactly. And yeah. So in light of this, and in light of the fact that this is most certainly not the last pandemic we will face, I'm particularly concerned about what this means for low-income countries, sub-Saharan Africa and elsewhere, as well as the middle-income countries that have extreme economic inequality, which is actually where most people living below the poverty level are. Is this the beginning of a new era in global health, characterized by a sort of triple threat of infectious, chronic, and pandemic disease? How are you thinking about this moment we're in and looking ahead? Is this a new public health era? And if so, what do we need to be doing to address? It's a big question. What do we need to be doing to address it?
Well, I think it is a new moment, but not the way you describe it.
Okay.
It's always been the case that we've had this tension and mixture of chronic disease and infectious disease, of structured medicine and community-based health. We've always had this. There's nothing new. Maybe the balance, the ratio shifts, with prosperity in certain countries, but this is an old tension just continuing. The real new tension, the new dynamic, and the one for which very few people coming out of schools of public health are trained, is the biological and other intersections between climate change and global health. Yeah. Lip service all over the place, but concrete reality and preparedness, no. I'll give you a classic example. Most public hospitals all over the world have been built, have been the location for their construction a century ago, 50 years ago, whenever it happened, tended to focus on two criteria. One was the old world belief that infectious disease facilities should be very far away from population centers, because somehow just walking by the building, you'd get infected. So, whether it was TB or general, pediatric infectious disease, so on, these things were stuck out in the woods, way out in the middle of nowhere, making them very remote and difficult for people to get to, for family members to see their loved ones, and so on. And then the second valuation of where to put a hospital or a health facility was cheap land. What's cheap land? Floodplains, right next to the coastline, riverbanks, places that are prone to severe weather events, tornado lanes. It's cheap real estate because it's crap. It's an awful place to be. When Hurricane Sandy hit New York City with record sea level rise during a full moon, with tidal waves pouring into the city, several of our hospitals were flooded. And all of the flooding meant they lost power. Yeah. They lost very expensive equipment that tends to go in the basement, like MRIs and radiology equipment, because it's heavy. They lost all their HIVAC systems, which tended to be in the basement. So they became unusable facilities, the hospitals. A simple survey around the world to see how many hospitals around the world have already had history of being hit by a hurricane, hit by a tornado, flooded or near flooded, losing electricity, failing to restore with their own generator power, and so on. Boy, that's such an obvious low-hanging fruit place to go, right? And yet I know I've searched and I can find no database where anybody's attempted to truly compile some sense of what's the inventory of medical facilities and how vulnerable are they to the challenges of climate change. Is anybody prepared to put resources into fixing them, such as moving your HVAC system to the roof, putting all your heavy equipment in the middle floor and bolstering up the structure, all sorts of things like that. You start going down the list of health and medicine, and you can see thousands of ways in which we're inadequately prepared to deal with emergency trauma care due to heavy weather events. We have no idea what to do about mass events such as hit Paris about 15, 16 years ago, of heat waves so overwhelming that you lose significant percentages of your senior citizen population in a single day. You know, we're looking at a huge range of climate-related issues that overlap into disease emergence, because as environments change, they release new sets of microbes, and they change the distribution of plant and animal life. So, for example, this year, for the first time, a swimmer was eaten alive by a great white shark off of Maine. Maine has never seen sharks before. It's never been the case that far north, sharks were attacking right at coastlines, right at the shores. Why are they there? Because all the migratory fish that they eat have found the mid-Atlantic region too hot, and they have been moving northward, and the sharks are following them. If you start looking around the world and asking, why are we seeing so many diseases that come from bats? Why are we seeing diseases that come from algae? Because we've changed the ecology in which these creatures live. And as a result, we're increasing our own vulnerability. We need to assume that bat-borne disease is going to be the new mainstay for humanity. Yeah. But it's more than that. You know, I remember years ago when there was the rare incidence of a dog getting distemper-like disease from a sea lion and vice versa. Now this is a routine event. Now, you know, a common warning to anybody who's got pet dogs going to the beach is keep them away from the seals and sea lions. And why are the seals and sea lions so likely now to carry morbilli viruses? Because essentially all the changes in the oceans that are the result of climate change have made the equivalent of mass measles epidemics, if you will. You know, it's in the same family as a virus, occur among many types of sea mammals. We're altering the planet in ways that put us at such elevated risk day in and day out for disease emergence, traumatic heat-related events, trauma injuries, and then you add one more layer to it, and that is a shrinking range of dietary inputs, because climate change also means certain types of food crops and animals that we rely on are diminishing in supply, coupled with overgrazing, overfishing, and so on. I think we're 10 years from now, we're going to routinely be looking at climate-associated mass disease events.
Right. And so do you think, I mean, I hate to say, I don't think anybody's particularly optimistic in this moment, but do you think that COVID will change thinking about the sort of the interconnection, particularly between public health and the environment that you've just described, and lead to change? I mean, I know that there are movements to talk about issues like planetary health and more integrative frameworks for thinking about these issues. They certainly aren't pervasive in sort of political thought leadership. Is COVID going to change the way we think about public health, prepare for future events? What are your reflections on?
Well, you certainly see that conversation going on right now. I mean, the climate community is looking at the public health response and saying, here's some ways in which, you know, they've done a really good job of bringing issues forward that to audiences that haven't been listening to us in the climate community. We need to learn from them about how they raise the sense of urgency and so on. But keep in mind that the biggest climate change related meetings have all turned into Zoom meetings.
Yeah.
It's very hard to negotiate anything about decreasing fossil fuel use on a Zoom call, right?
Yeah.
And there's always been a kind of unstated but recognized competition for financial resources between the climate change folks and the global health folks, which is most unfortunate.
Yeah.
Because both are arguing over inadequate funds regardless. Even your target that you set is too low to begin with.
Right.
Let's all get up into the trillions. And I think if there's a take-home message right now, it's a message that I recently heard former Prime Minister Gordon Brown and former Treasury Secretary Larry Summers issue jointly. And it is this: we're already looking at a scale of global loss to the economies of the planet that rivals anything that's happened since 1929. If we're very fortunate, by the end of this year, we'll be down for GDP in the United States by a mere negative 8%. Globally, we'll be down by a mere negative 5%. But if we don't have a vaccine that looks exciting and is actually going into use before the end of the year, or if we have one, we rush it into use and then it has side effects and there's a huge resistance against it, which would be much worse in my book than not having one at all. If we don't have changes in policies that result in enhanced social safety nets instead of directing resources to bailing out, say, like a multinational airlines, then we could very well be looking at a global sum total loss on the order of 30 trillion, that's trillion with a T, dollars to the global economy. And yet still, global health thinks that asking for $1 billion is a big ask. And the climate change folks still think that if they can get, $500,000 for a research project, that's like, phenomenal, right? The ask is not commensurate with the need and with the likely impact down the road. Public health should never again have to make the argument that they're economically justified. Right. And I doubt they will.
Yes.
I mean, they just need to figure out better how to use that argument. Climate change is still having to demonstrate and prove over and over again that climate-related events are costly, that they hurt big companies, they hurt employment, they hurt, on and on and on, the long list of things, and therefore it's worthwhile to invest front end, even at great cost, to lower the risk down the road. I think that if there's one thing that public health people should be doing right now, it's to really, really think through the algorithm, the calculus, if you will, of the relationship between front-end spending and back-end saving, and do it in a really rigorous, convincing way, reaching to logical, sympathetic ears on Wall Street and Fleet Street and the other streets. It's inexcusable that Fortune 500 companies are in some cases now realizing the greatest profits they've ever seen. I mean, Jeff Bezos in a single 24-hour period made 18 billion personal dollars. That's not company profit. Right. That's for one man on planet Earth. There needs to be a sense that this massive skewing, the wealth gap and the skewing of the distribution of the pain versus the gain has to be distributed in ways that deal with risk going forward. And I think there is the place where the global health community and the climate community should be allied. They should be working together to develop a genuine plan, not a, retro Marxist, wave the flag and scream about to each according to their needs, but a really rigorous strategic idea.
Mhm.
which harkens to things like the currency exchange tax or monetary transfer tax or a variety of other ideas that have come forward that could mean that the size of the pot
Yeah.
for addressing preparedness, both for climate change and uh, uh, public health, would be something closer to needs.
Mhm.
And we have to realize and recognize that that whole experiment of a pandemic preparedness pot at the World Bank failed dismally. That was a giant travesty.
Yeah.
And, everybody involved in that should pay a price because it's just turned into a boondoggle for the stock markets,
Yeah.
for hedge funds.
Yeah.
And similarly, WHO needs to demonstrate that it is capable of absorbing a tenfold greater budget and using it properly and
Yeah.
wisely. Right now, donors don't believe it is.
Right.
And the Global Fund needs to demonstrate that it's about more than just HIV, TB, malaria, and health system support. It has to become something much more profound and
Mhm.
capable of processing far larger grants and dispensations than
Yeah.
it currently handles. And then I would say for the NGO community, um, the most NGOs are accustomed to operating on a financial edge that is so knife-like that you just kind of lean two staff members in one direction and the whole boat flips. Um, Most NGOs are never on a budget that anticipates a catastrophic event that will make the needs for their services jump suddenly tenfold.
Right.
So whether it's the Red Cross, the big kahuna,
Yeah.
all the way down to little family NGOs trying to do health delivery services here and there, nobody's ready for the kind of scale of sudden urgent need
Mhm.
that we're experiencing right now with COVID.
Yeah.
Even a behemoth like Médecins Sans Frontières is, really at a loss. And it's not just about the money. It's about how do you scale up? How do you coordinate?
Yeah.
What are your logistics and supply chains? Have you anticipated who you plug in with that's engaged in emergency services in the countries in which you work?
Yeah.
And are you thinking ahead? What if sea level rose 6 inches in Mauritius,
Mhm.
right?
Yeah.
What will they need from us? And how can we adapt to that and be there for them?
Yeah.
Um,
Yeah.
and I think that's going for the next decade. Thinking along those lines is going to be absolutely essential. It's going to be the make or break for every NGO, every humanitarian group, every academic program, every school of public health. You either address these issues or you die ignominiously.
Mhm. Yeah. Yeah. It's the the challenge is immense, and I think you're right. The good news is there is a little bit of on a smaller scale we have a sort of a template for making the economic case for these types of movements. With the HIV, we were successful with that with the global HIV response to a degree, and so it's on a much smaller scale. We do have a template. I think the HIV, the sort of compelling case around HIV was sort of unique, and I wonder if we can recreate the conditions. Or recreate conditions that are sufficiently compelling to catalyze movement among the people who control, particularly the purse strings, because it's going to require a massive mobilization of resources, financial, human, and otherwise.
Well, Peter, going back all the way to when you and I worked together at the Council on Foreign Relations, as you well know, I have been ringing the death knell bell for a long time, warning that the whole world was overly dependent on two financing sources for
Mm-hmm.
all global health. And those were both American. It was Bill Gates, the man,
Mm-hmm.
and whoever was president of the United States.
Yep.
And we've now hit that moment where everything I was warning about is happening.
Mm-hmm.
We have a president that is out of his mind, and the whole global health mission is now being undermined as he pulls out of WHO and poo-poos every single multilateral institution in any way related to the pandemic.
Yeah.
And Bill Gates is finding himself pushed towards a more and more activist role.
Mm-hmm.
He finds that his allies that he would collaborate with aren't there anymore. And even he is finding a tension between the United States and China is creating great difficulty to execute any kind of meaningful programs on a global scale.
Yeah.
And as as I warned long ago, I was saying, I mean, this goes back all the way to like before the financial crisis of 2008. I was saying, every one of these institutions, whether you're an NGO, a multilateral, a school of public health, whatever you are, you've got to diversify your donor pool. Even if there's one place to go that's easy to get money, you've got to do the hard work to develop a far more diverse base, because the day will come when we have a president that actively sabotages those funding streams. Yeah. So you ask about HIV, and I think at this point, HIV has a certain very special status, because everybody recognizes, the notion of physician do no harm. You put these people on drugs, you take the drugs away, they die. There's no deviation from that. That's A plus B equals C. So, for the United States, even under a Donald Trump, to suddenly say, we're going to withdraw all PEPFAR, we're going to shut it all down, and all those people can just go find some other way to pay for their drugs. That's not going to happen, because even the most Looney Tunes members of the Republican Party who believe in vast conspiracies of crazy pedophiles operating under Hillary Clinton's control and all this kind of stuff, even they know it wouldn't look good for the United States to suddenly, allow millions of people to die. But do we want to get into the business of creating an HIV-like, PEPFAR-like infrastructure for one disease after another? It's not going to happen. And I'm worried it won't even happen with COVID, which means that we will come out of this situation 2 or 3 years from now, and COVID will be a disease of poor countries.
Yeah. Well, Laurie, always fun to talk to you. I really appreciate you taking the time to chat with me and all of the folks who are tuning in to celebrate HealthRight's 30th anniversary and Jonathan Mann's incredible legacy. Really grateful that you took the time to join us and share some of your thinking with us on health and human rights and the moment we're in.
Happy birthday, HealthRight.
Thank you. And I'll talk to you soon.
Okay, Peter. Thank you.
Thanks, Laurie. Appreciate it. Take care.
Bye-bye.
Bye.